Dear colleagues, today we are presenting the case of a patient who first came to our attention during her 7th week of amenorrhea due to suspected bilateral dermoid cysts. Dermoid cysts, or mature cystic teratomas, are benign ovarian neoplasms of dysontogenetic origin, meaning they arise from totipotent germ cells of the ovary, which are therefore capable of differentiating into various tissue types. On histological examination, mature cystic teratomas contain elements from all three germ layers, say ectoderm with skin and hair, mesoderm, the most common, with tissues such as adipose or muscle, and endoderm with mucinous content. Malignant or immature cystic teratomas are rare and contain undifferentiated embryonic tissues, typically of neuroectodermal origin. On ultrasound, these are usually solid, irregularly shaped, and show interlesional vascularization. Dermoid cysts in the general population account for about 20 to 30% of all ovarian neoplasms, with a peak incidence between 20 and 40 years of age. It is therefore rare for them to arise before puberty or after menopause. For this reason, it is the benign tumor most frequently associated with pregnancy. However, the presence of dermoid cysts on both sides is quite a rare occurrence, representing a small fraction of only about 10% of cases. At this point in time, no specific and well-defined risk factors related to their initial onset are currently known. As for clinical presentation, mature cystic teratomas are generally asymptomatic. When symptomatic, they can cause chronic or acute pelvic pain, a sensation of heaviness or pelvic tension, and urinary or intestinal disturbances due to mass effect. Transvaginal ultrasound is the first-line examination and is often diagnostic. These lesions are characterized by regular, well-defined borders. Generally, vascularization is absent or minimal and is peripheral. The content of the cyst is mixed. Within the cystic fluid, it is common to observe hyperechoic spots or streaks, either mobile or fixed, which are indicative of hair, sebum, and keratinous material, often associated with posterior acoustic shadowing. Another highly suggestive feature is the Rokitansky nodule or dermoid plug. This is a solid hyperechoic formation that protrudes into the cystic cavity with peripheral attenuation of the ultrasound beam due to the presence of adipose tissue. I will now show you the ultrasound video related to the case I mentioned at the beginning of this presentation. The patient is a primipara pregnant in the 7th week of amenorrhea who achieved the current pregnancy without the use of assisted reproductive techniques and has never undergone surgery. As usual, we begin our ultrasound examination with a transabdominal approach to rule out any masses or formations in the upper abdomen, and then proceed to the scan with a transvaginal probe. We immediately observe a well-implanted gestational sac at the uterine fundus, inside which an embryo with a heartbeat is visible, and the crown rump length, CRL, corresponds to the weeks of amenorrhea. In the right adnexa, hali, we can clearly identify the presence of a cystic formation with irregular borders, hypoechoic content, and negative on color Doppler, measuring approximately 30 by 17 millimeters. Inside this anatomical formation, there is a hyperechoic nodule with significant posterior acoustic shadowing, which is very characteristic of a classic dermoid cyst. We can notice how both ovaries appear to be adhered to the posterior aspect of the uterus. In fact, these are kissing ovaries. This diagnostic ultrasound finding is most likely related to an unrecognized inflammatory process, which, by causing the formation of scar tissue, has led to a specific type of mechanical traction of the adnexa, resulting in their displacement. Let's now move on to the study of the right adnexa. Furthermore, this area also appears to be occupied by a hypoechoic mass with well-defined and regular margins, and measuring approximately 17 by 16 millimeters. The identified mass lesion is negative on color Doppler imaging, and therefore in this specific case as well, it can be categorized as a dermoid cyst. Finally, we can observe the presence of another mass immediately adjacent to the left ovarian parenchyma, oblong in shape, multilocular, with an anechoic content and negative on color Doppler. This could primarily be an adhesion-related cyst associated with an inflammatory process of unknown origin, or it could be related to a hydrosalpinx. In this case, the observed septa are actually due to the folding of the fallopian tube itself, which appears dilated and contains clear anechoic fluid. I will conclude my presentation with a few take-home messages. The incidence of malignant transformation in mature cystic teratomas is very low. The main clinical risk actually remains ovarian torsion. In the absence of surgical indications, ultrasound follow-up is appropriate, initially at 6 months and then annually. During pregnancy, however, monthly monitoring is recommended. Surgical intervention, preferably via laparoscopy, is reserved for symptomatic cases or those with a size greater than 5 centimeters, always taking into account the patient's age and desire for future fertility. Finally, it is important to remember that the definitive diagnosis is always histological. Ultrasound, in fact, provides criteria for benignity that remain valid if the mass does not change in size over time. Therefore, during pregnancy, if the mass remains unchanged in size during regular monthly ultrasound checkups, its possible surgical removal with a histological examination can be considered after the delivery is complete.